Good morning, everyone. I'm Chen, and I'm a clinical assistant professor at the University of Iowa College of Dentistry. And I have been involved in TMD, non-surgical TMD care since about 2002. So today I'm speaking on behalf of the American Association of Dental Public Health Dentistry, AAPHD, to talk about our perspective from a public health perspective. So first of all, oops, not moving. Okay, thank you. So first of all, from our perspective, TMD affects both oral and general health. The musculoskeletal system is an integrated system that connects to the body through the head and the neck, and it is in charge of very important oral facial functions that affect the whole person. Next, please. Okay. So TMD affects the functions of this whole system with pain and functional limitations. Next, please. When we ask TMD patients, where do you hurt? These are the common images that they draw about their pain. So what you can see is that it's not just about oral or facial. It's the whole head, the neck, and the body. Next. And functional limitations are frequently reported by our TMD patients, which include, problems with eating, biting, chewing, yawning, talking, laughing, smiling, maintaining oral hygiene, having normal facial appearance, and even sexual activities. So when a person has pain and functional limitations like these, both oral and general health are significantly affected, including both physical and psychological well-being. Next. So let me just repeat. TMD affects oral and general health. Next. Okay. So secondly, from our perspective, treating TMD in later stages will not substantially change the prevalence or negative impact on the society. Instead, prevention and early intervention are essential in bringing substantial changes. So to understand this better, let's look at TMD prevalence across the lifespan. Okay. These graphs show the major pain-related TMD symptoms, such as frequent jaw pain with movement, frequent jaw locking, or any symptoms. And the red dots represent females, the blue dots represent males. So overall, the prevalence patterns are very similar across symptoms, but at different late stages of life, prevalence are different. Symptoms are relatively rare in early childhood, pain-related symptoms. But once kids enter teenage years, problems start to increase and blooms around early adulthood and stay high until 50, 60 years old and start to drop. Next. So interestingly, if you look at the common comorbidities of TMD across lifespan, here is what you will see. Next. First, let's look at headaches. Generally speaking, headache and TMD are highly commonly coexisting. About 80 to 90% of our clinical TMD patients, they report frequent headaches, mainly of tension type or migraine. And in headache clinic population, there are about 50 to 60% fulfill a TMD diagnosis. Next. So here we see the prevalence of tension headache and migraine. The red line represents males, and the blue line represents females. And this data is from the Global Disease Burden Study. We see that both conditions started early in early childhood. And tension headache, the prevalence increases rapidly through teenage years and stays high from 20s to 40s, and then thereafter start drop. And for migraine, again, the prevalence increases through adolescence and young adulthood and peaks around 30 to 40 years old, and then gradually drop after 50. Next. And if we look at widespread pain and fibromyalgia, these are the most worst case scenarios for chronic pain, and they are very resistant to current treatments. The prevalence of these conditions start increasing rapidly around 30 to 50 years old, and then blooms later in life in both genders. So this is female, this is male. Next, please. If you look at other musculoskeletal conditions, next, what you will see here is that like neck pain, which is also commonly comorbid with TMD, it starts early in life. And next, this is osteoarthritis, and which starts pretty later in life. So next. So if we come back to TMD, we see that at different stages of life, the clusters of comorbid conditions are different. And earlier in life, there are more regional issues like headaches, TMD, neck pain. But later in life, when it comes to like widespread pain, fibromyalgia, and later osteoarthritis. So if you really want to reduce the prevalence and impact of these late-stage aspects like fibromyalgia, arthritis, or widespread pain issues, risk assessment, prevention, and early intervention have to be in place early on. In addition, if a person does not show common patterns of these comorbid issues, such as having arthritic change or widespread pain in their early 20s, then they are representing different subgroups with different vulnerability to pain and functional limitations. And we have so many such kind of subgroup issues within TMD that we need to understand better regarding their disease mechanisms and regarding targeted prevention and intervention approaches. But currently, we lack specifications. Next. So we are treating all of these different subgroups with virtually identical treatments for TMD. And this needs to be improved to tailor treatment to better match individual patients' type, level, and mechanism of TMD. Next. Another important point from public health perspective is that insurance policies really need a total makeover. Next, please. So TMD in the U.S. is currently considered a medical condition. Most physicians are not trained to evaluate or manage TMD. So we're still studying, we don't know exactly what is covered in undergraduate, in predoctoral and postdoctoral curriculum. But from our communications with medical colleagues, it seems that TMD is mentioned in anatomy class in medical school, and then is covered in some specialty training such as ENT. But there's no general training in predoctoral education. Dentists are better trained at this point to evaluate and manage TMD. In dentistry, TMD evaluation and management typically are presented in predoctoral education through different dental disciplines, such as prosthodontics, occlusion, oral medicine, oral diagnosis, oral surgery, and general dentistry treatment planning courses. And there are some dedicated advanced postgraduate dental training programs, specifically in oral facial pain management, that TMD is one of the primary foci. And oral surgery programs also include TMD management in surgical aspects. So we see dentists are better trained to evaluate and manage TMD at this point. And dentists are willing to and capable to provide TMD care. However, medical insurance companies, they won't credential dentists for providing a medical service. So dentists cannot receive medical reimbursement. And generally, dentists are not even authorized to request image studies or treatments for TMD. But on the other side, dental insurance won't provide TMD coverage because this is a medical condition, not a dental condition. So dentists can't receive any dental reimbursement either. So I can go on and on these insurance issues, but the main point here is that reinsurance policies really need a total makeover. Next. So to summarize, from our public health perspective, we think that risk identification, prevention, and early intervention are essential in improving TMD care. And here are some of our recommendations. But primarily, we think the issue is to improve insurance policies to really unite medical and dental coverage for TMD. And also, we should develop policies to encourage risk screening, prevention, and early intervention. In addition to that, we think that education, research, and clinical care should all follow to improve the risk assessment, prevention, and early interventions. And that is all what I would like to say. And I want to thank the committee for inviting AAPHD to share our public health perspective. And also thank you, AAPHD, for offering me this opportunity to speak out. And also I want to special thank University of Iowa, particularly College of Dentistry faculty and staff, for helping prepare this presentation. And thank you.